Hello, I'm Dr. Juliette Skinner and I'm the Medical Director of Barbados Fertility Centre. The purpose of this video is to provide and update you on what we know about Zika. Prior to 2016, no association had ever been recognised between Zika infection and a rise in congenital anomalies in babies, such as microcephaly. The reason that this outbreak has allowed this to be recognised is the sheer numbers of people who have been infected around the world. This worldwide epidemic has seen people confirmed with Zika infection in over 50 countries. In January of 2016, global attention focused on the potential risks that Zika infection was associated with a spike in microcephalic babies born in Brazil. A tremendous effort by the WHO, CDC and other agencies to endorse and provide the funds and manpower to research the association and develop potential tests, vaccines and understanding of Zika infection was initiated. So where are we now? We now have data to link Zika infection in pregnancies to adverse pregnancy outcome. Most seriously, congenital anomalies such as microcephaly, brain and eye anomalies. The actual rate of anomalies are still to be accurately determined, but mathematical remodeling suggests that if a pregnant patient gets Zika in pregnancy, the risk of having a baby with congenital anomaly is approximately 1%. While the odds of 99% of there being no risk to the pregnant patient of having a baby with an anomaly are still excellent, it obviously has led to a big concern for women who are pregnant and get Zika or are potentially exposed. Antenatal screening recommendations have been made by the colleges of Obs and Gynae. With respect to the mode of transmission, while 99.9% of people who get Zika do so following the bite of an infected mosquito, rarely it can be sexually transmitted, and this new finding has led to new recommendations that men who have been infected should use condoms for 6 months following the infection. This was made on the basis of 6 cases where sexual transmission was shown likely. Thankfully, for many countries, including Barbados, the prevalence of Zika infection has fallen considerably as we move away from the onset of the epidemic. The Ministry of Health in Barbados recently released a statement on the 28th July that there had been no confirmed cases of Zika on the island in 12 weeks. With respect to the guidance for women who are considering a pregnancy, this association does raise the question, should they consider deferring pregnancy, or indeed if the risk of waiting is significant, such as if the woman is older than 35 or perhaps younger with a diminished ovarian reserve, then should they proceed to attempt pregnancy given the relatively low risk of both getting Zika infection and indeed the lower risk of an adverse outcome, which, while potentially serious, is still a low rate. Research continues to provide added answers, and we are anxiously awaiting updated data from the very large cohort of women in Brazil and Colombia who have confirmed Zika and are pregnant. This data will help guide us to the risk, the impact of whether it matters when in the pregnancy that Zika infection occurs, and will allow us to better be able to guide patients. So far, there is data to suggest that infection in the 3rd trimester does not seem to be associated with congenital anomaly. We therefore await the further data in due course.